Hey everybody, welcome back to the ECG of the day. My name is Reed, and don't forget to download the PDF of today's ECG document down for the description below. And if you enjoy these videos, consider liking the video and subscribing to the channel for more. So let's jump into it. So first thing I want to do is look at the force, and really what I mean is just get an idea of what is going on with this rhythm. And so maybe I'll choose this lead 2 rhythm strip, and I notice that I've got a narrow complex rhythm that if I start to march them along, they don't seem to be perfectly regular, right? Some of the R to R intervals are a little bit longer, and then it gets a little bit shorter. And if I look, some of them are really short, some of them are much longer, right? And so there's just kind of this intermittent, not much of a pattern to it throughout the entirety of this rhythm, right? So it's definitely an irregular rhythm, right? I've also got this funky beat right here. It's a wide complex beat that's a little early, so we have some type of premature beat there. And so this is an irregular rhythm, and so I think maybe, this could be a fib or a flutter, right? Anything that would cause the AV node to pass signal down in an irregular pattern, right? Maybe it's at some level of second degree AV block, because we know those ones can do that. So my next thing is to look at what the atria is doing, right? So we'll kind of look at what the atria is doing, and we see that maybe if we scan through, we see that there is a baseline activity within the atria, but I don't see any distinct P waves before my QRSs. And so sometimes you have to scan through multiple leads to make sure that that's the case, right? Maybe come up here to AVL, I don't see any. So I don't see any P waves. And so in this irregular pattern that is really has no regularity to it, right? It's not like we have beat, beat, drop, beat, beat, drop, or beat, drop with no atrial activity, and actually some baseline activity, really best seen here in V1. You can see there's kind of this baseline activity in the atria. This is pretty characteristic for atrial fibrillation, right? And so remember that atrial fibrillation is a diagnosis where the atria is having all these reentry circuits, and so the AV node gets bumped into by those reentry circuits and will pass the signal down the His-Purkinje system in the normal fashion. But the AV node is a bystander, right? And so it's going to pass fibrillatory waves down in an irregular fashion. It just depends on kind of when it gets bumped into by these signals and when is it not refractory from the previous signal, right? And so that changes from beat to beat. Okay, so we've got an atrial fibrillation. We know that AFib, we need to characterize it by the ventricular response. So how many QRSs do we have in 1 minute of AFib? And so we can't really measure one R to R interval, right? If I measure the rate here, that wouldn't be the same as if I measured the rate here. So what I can do is I can count these. I can count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. I can count 16. I can multiply that by 6 because this is a 10-second strip, and so 16 times 6. Got to do math in public now, so 6 times 10 is 60, 6 times 6 is 36. So 96 beats per minute, alrighty? So we have a AFib with a normal ventricular response, right? Anything between 60 and 100 is appropriate. If it was over 100, it would be a rapid ventricular response. If it was less than 100, it would be a slow ventricular response. Okay? So now that we've kind of characterized what the atria is doing, it's fibrillating, and what the AV node is doing, it's passing the signal down 96 times a minute. Let's see what the ventricles are doing, okay? So we get to measure our QRS. So we get a narrow complex QRS, right? Our QRS duration is less than 120 milliseconds. QRS is upright in lead 1, and it's upright in AVF. What does that tell me? It tells me that my QRS axis is typically down and to the left, which is normal axis. You can see I've got small septal R waves that growing and become dominant around V4. That's okay. All right. I could look at my QT interval to see how is my repolarization. So I find a lead that's got a nice QT interval that we can look at. Maybe we can choose lead 2, right? And so if you look here at the midway point between these R to Rs, you can see these T waves are not really even close to the midway point. And now we're going to look for are ischemic changes, right? Pathological Q waves, which tells me if there's a previous myocardial infarction. I don't see any. And then we have ST and T wave elevation depression. I don't see any there, right? And you always look through your anatomical kind of landmarks, right? There's some non-specific changes, we'll say. So the last thing we need to do is define this premature beat, right? And so in atrial fibrillation, we can't have a premature atrial contraction because the atria up here is just fibrillating. We can't really have PACs, like that doesn't really happen, right? And so this must be a premature ventricular contraction. So this can be either a PVC or it can be an Ashman beat. Now, if you remember, Ashman beat is essentially a functional bundle branch block where if you have a premature beat that's conducted through the AV node, just as one of the bundle branches is refractory, then you can say that that could be an Ashman beat. And so I look for any real evidence that this would, kind of correlate to either a left or right bundle branch block morphology, and I don't see any. And so I'm going to call this a premature ventricular contraction, right? A PVC. Okay. So what are we going to label this, right? We're going to put it all together. We're going to say we have a AFib, atrial fibrillation, with a normal ventricular response at 96 beats per minute with a single premature ventricular contraction. So hope this helps. Hope help you understand the pathophysiology that kind of rules atrial fibrillation and how things work. And if you have any questions about it, feel free to ask me in the comments. And if not, thanks so much for watching. I hope you have a great rest of your day. Take care.